So 6 months later, this patient was symptom-free. He had a flexible sigmoidoscopy, and that was sort of what his bowel looked like. It was pretty healthy and pretty normal. Now, did you get around to discussing non-drug options? And there are a lot of non-drug options here for any patient, but number one is smoking. Now, you can argue that there is only one reason to smoke, and that is to keep your ulcerative colitis in remission. And unfortunately, it's true. But if you've got Crohn's disease and you smoke, you're much more likely to get relapses, fistulas and complications. In fact, with Crohn's disease, if you're a smoker, what they're saying is if you can stop smoking, that has the same effect as taking steroids on your Crohn's disease. So smoking definitely bad for Crohn's. Now with ulcerative colitis, even if we see a patient who's a smoker, we'd say stop smoking. But it's quite noticeable that a patient will often present with ulcerative colitis within 6 months of giving up smoking. And I'll see that in my clinic once or twice a year. So it is quite common. But certainly focus on smoking. I mean, the other non-drug therapies, we're talking a little bit about diet, a little bit about prebiotics, probiotics, fish oil, turmeric, I'm afraid to say. And the Mediterranean diet actually has been shown to be more effective in Crohn's disease. But in Sarah, you may have covered it today too. You've got to differentiate diet affecting symptoms or diet affecting disease. And so most of the work that Sarah will be doing is around symptom reduction from low FODMAP and so on and so forth. Correct?
Yeah.
Cool. Right. On board.
I dabble a little bit on the other side of the diet is quite inflammatory.
Yeah. Oh no, I'm not saying you shouldn't. You should absolutely. Yeah. I mean, as I say, going down that concept Mediterranean style diet and sort of a less inflammatory diet. Yeah. The next case, which I've called the bad. So we have a young patient presenting with alarm features, weight loss, pain, bloody diarrhea. Blood tests reveal anemia and raised inflammatory markers. In fact, his fecal calprotectin is sky high. And if you're listening to what I said before, that is, I'll be thinking inflammatory bowel disease. First thing, inflammatory bowel disease is not limited to a Caucasian population. Asian populations, India in particular, we're seeing high rates of ulcerative colitis. Whilst a few years ago, for a number of reasons, possibly because we weren't looking, we just didn't see it. Unfortunately, it is associated with westernisation of diet, so that sort of gives us a bit of a clue to about what might be going on. So just because I put Asia in the title doesn't take away from the fact that this could be and probably is inflammatory bowel disease. Then you're talking about the diagnostic techniques available, or diagnostic tests available to make the diagnosis. Obviously colonoscopy, but the other ones that could be used in addition to colonoscopy would be gastroscopy, because, as I said, Crohn's disease can affect the upper gastrointestinal tract, particularly in younger patients. And also you're looking at the small intestine. There are various options available. MRI enterography is probably the preferred technique, and that's also what I was asking about how easy it is to get those tests. And you may not be able to answer that because it's obviously is done by your specialists. Or some places will use capsule endoscopy, which you probably aware of. But the drawback with capsule endoscopy when you have a suspicion of Crohn's disease is that you may have a stricture in the small intestine, which is going to get the capsule obstruct, or you're going to obstruct your small intestine with the capsule. So there are ways around that. You can use a dissolvable capsule first, and if that comes through, you can then go ahead and do the standard capsule test. Anyway, if somebody, you remember the X-ray shows you toxic megacolon, obviously colonoscopy is contraindicated there. You'd perforate the colon and it would become a surgical emergency. And so it's a bit of a balance. If someone's acutely unwell and you have a strong suspicion that this is inflammatory bowel disease, you'll try and get them partway into remission before you do invasive tests like colonoscopy. So it isn't an easy answer. It will depend on how the patient presents. But you're absolutely correct. That's not too bad, believe it or not. It looks terrible. I haven't got any really serious ones up there, but there are times when you put the scope in and say, "Oh, I'm not going any further, I'm coming out." Yeah. So head colonoscopy, this is what we saw. Biopsies came back and said this is inflammatory bowel disease. And just a reminder about the complex immune reaction in the gut for inflammatory bowel disease. And I'm not going to talk about this specifically, but just highlight how many arrows there are, how many names there are. And if you're looking at development of new therapies, each one of these pathways is being targeted with new drugs. So it's a huge area of development. Unfortunately, I have to say, as I said before, as I've already said, no great breakthroughs. Ulcerative colitis, or Crohn's disease, if you see a granuloma, and you more often than not don't, but if you see a granuloma, you know that you're dealing with Crohn's disease. But just a simple biopsy, it may not necessarily give you the differentiation that you need to make the diagnosis, which is actually one of the learning points I'm making with this case. You'll see that basically you're going to see a chronic inflammatory infiltrate, and that it could be this or it could be that. And so but the thing is, you then match that with the clinical presentation, the endoscopy findings, and that will give you your diagnosis. So, I can't remember the last time I had a patient with Crohn's disease with granuloma found. It is if you see it, you sort of, wow, that's exciting. I know exactly that this is Crohn's disease. Or you know it's Crohn's disease because you're dealing with the small intestine. But if you're dealing with the colon, it could be Crohn's or it could be ulcerative colitis. So obviously with this patient, we're talking before about maintenance therapy. And the best maintenance therapy is immunosuppressants: azathioprine, 6-mercaptopurine, and methotrexate. They're very effective at bringing patients into remission. They're very slow in bringing a patient into remission. It could be 8 to 12 weeks before remission is obtained. You do need to monitor them for toxicity, and safety is an issue, particularly with methotrexate. Though certainly with azathioprine and 6-mercaptopurine, it is they're considered safe for pregnancy and reasonably safe for breastfeeding. But there's always debate about that, and often the patient themselves will say, I don't want to be on these drugs when I'm pregnant, or I don't want to breastfeed whilst I'm taking these drugs. But then if a patient comes and says, look, I want to start a family, I'm on azathioprine, I want to come off it, you've got to balance a risk. Their fertility is going to be significantly affected if they have florid Crohn's disease or florid colitis. So that you say, if you want to get pregnant, you've got to be on the drug. So it's a difficult balance. But there's a huge literature of patients on these drugs during pregnancy. I'd never insist a patient takes the drug if, say, I'm talking about the pregnancy scenario, or if a patient says I want to come off it, provided they had at least a 2-year history of stable disease. I would say, okay, let's do this, but you have to have fecal calprotectin on a regular basis. You have to have this on a regular basis. I need to see you on a regular basis. Because fecal calprotectin is an early marker of disease recurrence. I didn't talk about that before, but it can be used in that context. Yeah. So this patient was started on azathioprine. After 8 weeks, no improvement. And we should have seen some improvement by then. And so the first thing we think about is there an issue in the metabolism of azathioprine? Now, you may have seen people getting what are called 6-TGN levels done, or TPMT levels done, which are ways that we can measure whether the drug is being metabolized as it should, because there are various pathways. This is the good pathway. We want to see 6-TGN being generated because that's going to have the anti-inflammatory effects. We don't want to see 6-MMPN being produced because that's hepatotoxic and also has an effect on your blood cells. And the switch here does seem to be dependent on your genetic background, and so we can do a genetic test to see which way you're prone to do it. Some people will do that routinely. Other people will say, we'll start you on azathioprine, we'll start you on 6-mercaptopurine, and we'll monitor this, and we'll monitor for complications. There's no absolute right or wrong about that. So let's just highlighting what I've just said. So this patient, 6 TGN levels were well and truly within the therapeutic range. He was getting worse. He was developing symptoms of obstruction. He was actually referred for surgery and had a partial resection of his large bowel. Now, with Crohn's colitis, this is not too unusual. Alarm bells weren't ringing, but we're thinking this is unusual. And this is why it was unusual, because this is what was found in his colon. He had tuberculosis in his colon. So the point, very good.
So TB of HIV.
So always have an open mind when you're assessing patients. Sometimes it is not what you expect. Last case of this case series, and we should have time to briefly go over the paediatrics as well. So, 18-year-old student. As I say, all these are real patients. I've not made up the quote. This is what she told me, so I'm not being sexist, okay? And so she presented with a fistula. She had severe Crohn's disease affecting her colon. Now, when we're talking about fistula tracts or fistulizing disease, it's a different level of severity, and we know that standard treatment, and what I mean by standard treatment, the immunomodulating drugs, the 5-ASA drugs, the steroids, don't work. In fact, steroids, you could argue, are probably contraindicated because of the risk of infection. So we have to do something different for her, and this is when we're starting to use the anti-TNFs. This is the infliximabs, the adalimumab treatments, which neutralise the TNF-alpha. Remember that this is a subset of that more complex diagram I showed you before. I won't go into it, but apart from the fact that the infliximab, this lovely triangular thing, just blocks the activation of the inflammatory cells, and it's very effective. It's been around now for more than 20 years. But do they work? Well, once again, you've got to remember this rule of thumb of 40%. So 40% of people with severe disease given infliximab or Humira, which is adalimumab, will be brought into remission. It's not. It sounds really bad, but actually, this is actually quite a significant advance in managing severe inflammatory bowel disease. So we can measure efficacy by induction of remission, reduction in steroid use, closure of fistulas, a healing of the gut. In fact, we've now guidelines for treatment of inflammatory bowel disease for the first time ever are now saying complete healing of gut lining, or the inflammation in the lining of the gut, is the preferred goal of treatment. 20 years ago, that was inconceivable that we could ever see that happening. So that can be achieved, but the thing is, some patients don't respond, and that's the issue. We can look at quality of life, and we can look at surgery. And just to highlight, I said that the rule of thumb is about 40%. So about just under 40% of patients will be brought into brought into remission or induction by treatment. But once they are in remission, longer term, 12 months or more, we're looking at maintaining more than 50% in remission, if you follow what I'm saying there. So there's obviously a group of patients that are not responding or not being kept in remission, but there's a good number of patients that are. The other point I want to highlight is markers of disease activity, and this is still a quandary. So we can use what's called the Crohn's Disease Activity Index. In fact, if you're looking at your special authority application forms for Humira, you'll see that you have Crohn's Disease Activity Index. It's a symptom-based index, and so if you've got severe irritable bowel syndrome, nothing to do with inflammatory bowel disease, you'll probably have a high CDAI too, because it's a symptom index. So it's a poor tool, but it is really the only tool that we have to decide how severe disease it is, apart from doing invasive tests like colonoscopy. So a patient can have severe disease and not have very many symptoms. A patient can have a lot of symptoms and not have severe disease. This is the point about combination treatment, and that you can see if you have a combination of infliximab and azathioprine, so anti-TNF plus an immunomodulator, you're going to get better results. But it also means a bigger hit on your immune system, which people are worried about as well, and I'll come back to that. When we're talking about surgery, this is just to give you the concept about what's happening to the gut long term and what happens if you have surgery. This shows over time a typical course of somebody with inflammatory bowel disease. A relapse, a remission, a relapse, a remission. And if you look at it on that one dimension, this is what it looks like. But you've got to remember, each of these times you're having a relapse, there's some damage being done to your gut. And that damage doesn't necessarily heal completely. You won't get complete regeneration of gut tissue. So you get a cumulative effect on gut function, or impairment of gut function over time. So then, as you know, surgery is sometimes indicated. There may be a stricture or an abscess, and once again, you're taking away gut. You're also having an effect or impairing gut function. So by the end of a period of time, this is the cumulative effect of the disease and surgical treatment. So the message is, we've got to get in here. We've got to stop that slope of worsening gut function due to recurrent disease and then requirements for surgery. So 10 years on, this patient was healthy, believe it or not. She started on Humira and she did really well. Went to university, decided she was working in health in a steady relationship. That's key, because when these, in the teenage years, you imagine the psychosocial effects of having bowel disease or fistula or colostomy. Sorry, I hate to put that joke up there. I'm not sure if she does wear a bikini. So this is just a summary of our standard treatment for inflammatory bowel disease, for induction of remission, maintenance of remission, and then just highlighting the adverse effects. Just notice antibiotics they don't induce remission, they don't maintain remission, they're used for infective complications only. The PHARMAC requirements for funding mean that you have to trial a certain number of treatments before, but yes, the expectation is that they'll be on, firstly they should be on immunomodulator therapy, azathioprine, immediately or almost immediately, and if they're not responding to that, or they have extensive or severe disease, then to be started on an anti-TNF. So the first thing to note about inflammatory bowel disease in children is that it is increasing. This graph here is looking at data that we've got from Wellington Hospital, where you can see from in a 10-year period, there's been almost doubling in the incidence. There's new cases presenting to the hospital. So there's something happening out there. We don't know what it is. You talk about diet, you talk about lifestyle, but we just don't know. So just two cases I want to highlight, Rosie and Sam, and superficially they look very similar. 12 years, 14 years. Rosie, 12 months history of malaise and headaches. Sam, 4-year history of headaches and vomiting. Rosie, a bit of a reluctant historian, some abdominal pain. When pressed about it, Sam, he freely admits to having abdominal pain. Rosie, low on the weight and height centiles. Sam also on the low on the weight and height centiles. Interestingly, 12 months previously, Rosie had been seen by another physician for iron deficiency, which was quickly corrected with oral iron and was therefore not followed up. Now, the point here is there any difference in presentation in inflammatory bowel disease in children? And the answer is obviously yes. So, you think of pain. Yeah, pain's a common. This is presenting features of Crohn's disease in children. with how many percent of patients presenting with each symptom. They'll obviously have more than one symptom, that's why these are all high. But pain is a common presenting feature, same as adults. Diarrhea, common presenting feature, same as adults. Rectal bleeding, maybe at 50% of patients present, which is maybe slightly different to adults, maybe slightly less. But what we are seeing, we've got growth factors here. In other words, weight and height. So coming off the centiles. That's, whenever you see that, you know that is an alarm sign. We're also seeing extrasystemic features are quite common presenting features. And what are these? Well, you've got mouth ulcers, joint symptoms, iritis, skin things such as erythema nodosum. And so these are quite a common presenting feature of inflammatory bowel disease in children. So if you're seeing a patient, failure to thrive, tummy pain, and then you're seeing something like this, to me, that's inflammatory bowel disease until proven otherwise. And there's certainly a lot of cases I've seen where that has been sort of, oh, that's interesting, I don't know what that rash is, let's see you next month. So just be warned. So moving through with Rosie and Sam. Rosie, blood tests, slightly anemic, raised inflammatory marker. Sam, okay, so 5 is sort of marginal. Always do the Coeliac negative. Fecal calprotectin, strikingly high. Fecal calprotectin, moderately high. And I do the a lot of pediatric inflammatory bowel disease and endoscopy, and there are certain criteria I would use before I progress. One of them would be that there has to be alarm features present or raised fecal calprotectin, and so for both of these patients, they pass that threshold. Rosie had very obvious colitis, mucosal edema, multiple small ulcers in the colon, more characteristic of Crohn's disease. And Sam, it was normal. So the points I want to raise here is, how does management differ for children versus adults? Sarah highlighted this today. Whether it's a child or an adult, inflammatory bowel disease is a disease of nutrition. You have to make, what's happening to their calories, what's happening to their vitamins, minerals, etc., the micronutrient intake, and they have to be corrected. Point about iron deficiency in particular, because iron deficiency is quite common. If you've got inflammatory bowel disease, you will not absorb oral iron. Full stop. Don't even try. If you're iron deficient, adult or child, they have to have iron infusion. They will not absorb it orally. All you're going to do is going to give them gut symptoms without any significant improvement in their iron stores. Surgery, unfortunately surgery does have to be considered in children, and just remember that slide I showed you previously about the cumulative effect on gut function with surgery. So we use it very conservatively, and it's really only for surgical complications such as abscess, obstruction, and so on. Psychiatric support, depression in particular, is very common in children with chronic inflammatory disease or any chronic disease. And you've got to be aware of that. You've got to address that. They need to have psychological support in place. And it's not just for the child. It's often the family. And the family need to have that support. And so it really does become like a multidisciplinary team approach to managing these children. The other point about psychiatric support, not really psychiatric, but there are organisations like Crohn's Colitis New Zealand that have annual summer camps for children. They're magic. There are actually studies around the world that showing children who attend these camps get better outcomes from in managing their disease. So, if you have any children in your practice, make sure you mention that to them. Make sure that they're linked in with Crohn's Colitis New Zealand. Immunisation, absolutely important, because I've just been talking about all these immune suppressive drugs, anti-TNF, etc. If someone's established on an anti-TNF, they can't have a live vaccine. So make sure the vaccination schedule's up to speed. As soon as you've made that diagnosis, check. If they've missed a vaccination, go back. They need to have that vaccination then, and then consider long term if someone needs a live vaccination. Probably the biggest one would be yellow fever. No one knows whether they're going to travel to a country with yellow fever. But if you're on infliximab, and I've had a lot of patients, well, not a lot, a few patients who had to change their travel plans because they just cannot have a live vaccine. And then cancer and other risk monitoring. Yes, the long-term risk of inflammatory bowel disease does increase your risk of cancer. Lymphomas, and that's why I was highlighting before about the combined immunosuppressive effects of an anti-TNF plus azathioprine. There is an increased lymphoma, but it's still rare. It's in the order of about 1 in 10,000. But patients will know that. So you need to have that conversation with patients so they understand relative risk versus absolute risk versus the risk of doing nothing and having their disease ruin their life or ruin their gut. And they have to, you have to be able to help them through that. Long term, there is an increased risk of bowel cancer with both Crohn's and colitis. And so that's the other, but that's an issue that's, maybe 10 to 15 years down the track from having the diagnosis confirmed. And so eventually patients will need to be on regular surveillance programs for that.